First of all, my greetings on the occasion of Ranga Panchami to all. Today is the festival of colors at Indore. Huge procession being carried out. About more than 100,000 people come on streets and celebrate Ranga Panchami with all sort of colors. So my talk is on role of Elizaro in infected non-union cases of humerus. So what would be the challenges? First of all, the axial micromotion, which is the key for union, might be missing because of being not weight-bearing bone. There is a long lever arm deforming force because of distal forearm and hand, and activities of daily living going on. The bone being very proximity to chest, again the apparatus becomes difficult to manage. And of course, everybody of us knows the neurovascular concerns while doing surgery, particularly in complicated cases. So, straightway going to the cases. No more theory. Atrophic infected non-union humerus being fixed. You will have to observe certain peculiarities of apparatus of humerus as opposed to that of femur and tibia. See, the proximal and distal wings are very near because of being small bone. You can apply unless you neglect the basic principles. Non-union side, apparatus in position and union. Another case. Case of infected non-union following plating. In India, the patients are so much so negligent. You can see the oblong holes. It was hell of a time finding place to pass wires. From where should I fix the distal fragment? Very tough, very difficult. But somehow I could catch hold of the distal fragment. Assembly has a long span. Patient in apparatus. It was a corona time when I removed this. You can see the sanitizer and mask on his face. Union. Another case. Again, a case of infected non-union following plating. This time, the span is much bigger between the proximal two rings and the distal two rings. Middle two are spanning the fracture section. See the range of motion of shoulder and the union status. Another case, very old case of mine, more than 18 years. Again, infected non-union following plating. Plate. These X-rays only tell that how old they would be, being a conventional radiological technique. Old type of X-rays in apparatus, patient in apparatus, and the union. Now this time, this case has come to me because of failed intramedullary nail. The nail was broken inside, again got infection, atrophic type of non-union with broken implant, middle third, distal third junction, apparatus, union. Range of motion. Most of young generation people might be worried about the range of motion of shoulder and elbow in cases of humerus Elizaro cases. But no, they do well. Particularly post-operative physiotherapy is most important, as in cases of Elizaro near knee or elbow. You can see the movements. See whether the video is working good. we have to be careful while passing wires for assembly. It would not be okay, certain. This is the first case. This is the second one. This was having the all granulation tissue in the very first slide. A rare case, use of Elizar apparatus for compound fracture clavicle, medial 1/4 and lateral 3/4 junction fracture of clavicle, threatening to impale subclavian vessel. That's why I fixed it. Otherwise, routine clavicle I don't fix. This is just to show you that this is also possible. I would be failing if I don't thank my mentors. First is Professor Satyendra Kozhatmato from Bishkek, Kurgan, whose daughter came to Asami 2023 last year. He is my first mentor for Elizaro. This great personality is known to everybody. Professor Gabriel Abramovich Elizaro, and myself sitting in his chair, I was fortunate enough to sit in the chair of the master at Kurgan Institute. This lady is my first mentor for life, my mother, 58-year-old photograph. This lady is our Rajmata Ahilyabai Holkar, the most revered and respected lady in our Indore and Malwa region. And this is myself with Director Professor Alexander Gubin at 2019 conference, where I had a chance to present paper also. Thanking you, all of you, for patient hearing. Thank you very much. Jai Hind, Jai Bharat.
So I will be talking about management of radial club hand with a two-staged approach. So radial club hand includes varying degrees of dysplasias involving the radial half of forearm, wrist and hand, and it can be classified according to the modified Haeckel's classification. The type 1 is mild dysplasias, and it may progress up to type 4, which is complete absence of radial aspect of forearm and hand. And for this talk, actually I will be restricting myself to type 3 and type 4 types, which are considered to be the most severe and they need centralization procedures. So when the child presents early, that is before 2 years of age, the ideal treatment consists of soft tissue stretching and splinting, which should be starting at birth, and then stabilization is done at around 12 to 18 months of age, and policization is added at around 3 years of age. And different types of stabilization procedures have been described, but centralization is still widely done and it gives satisfactory results. However, in older children with neglected cases, if you go for centralization directly without any previous distraction, then it is very invasive and complex surgery. It requires very aggressive soft tissue releases and may require ulnar shortening also, which further shortens the forearm. And the risk of neurovascular stretch injuries are always there. Whereas distraction before centralization avoids these aggressive surgeries and it avoids neurovascular stretch injury. So let's see the surgical steps of these two-stage procedures. Basically, in stage 1, we distract the soft tissues either with a cast, Jess or Elizaro, which depends on the age of the patient. And in stage 2, the centralization of wrist is done. For example, this 7-year-old girl with type 4 radial club hand. So in stage 1, the Jess is applied. Now this is a very simple frame. If the deformity is very severe, you need to do an articulated Jess. I will be showing those pictures also. And recently we have started using the Elizaro. So in stage 1, the Jess is applied and then differential distraction is done with more distraction on the concave side, like we do for the CTEV cases. And once adequate distraction is done, the centralization of wrist is carried out with dorsal approach to wrist and Jess is removed intraoperatively. So So for centralization, a lazy edge-set incision is given on the dorsal aspect of forearm. The capsule is incised transversely, exposing the distal ulna and carpal mass. The fibrous band, if still found, and the radial analog, if you find it, then it should be released. However, if your distraction is adequate, you hardly need to do even these releases. The carpal mass is reduced over the ulna, and stabilization is done with K-wire passing through third metacarpal. And the tendon transfers which have been described in standard centralization procedures, we don't do any tendon transfers and found that it doesn't affect much. The outcome is almost similar even without any tendon transfers. And an ulnar osteotomy is added if the ulnar bowing is more than 30 degrees. Post-operatively, the cast immobilization is carried out for 6 weeks, followed by molded forearm and wrist brace, and we leave the wire in situ for an indefinite period and remove it when the tip reaches the carpus. So this gives us some more time for the distal ulna to remodel without any chance of recurrence. And these are results in 9 patients with 10 hands. The oldest child was 9 years of age, and the longest duration of follow-up was 4 years. And we can see both clinical as well as radiological parameters improved significantly, and according to Bain and Blue criteria, satisfactory outcome were seen in 9 out of 10 hands. So coming to some cases, this was a 1-year-old boy with flexible deformity. So as he presented early, serial stretching casts were given, followed by centralizing the wrist. And these are the follow-up images showing satisfactory reduction, alignment, and good remodeling of the distal ulna. These are the clinical images. Now this was a 2-year-old child with relatively less flexible deformity, and we can see the ulnar bowing is also significant and more than 30 degrees. So this is the articulated gest that I was talking about. You can apply this for more severely angulated deformities. So this was stage 1 where gradual distraction was started, followed by centralization, and ulnar osteotomy was added. And these are the follow-up images. Again, wire was left indefinitely, and this is the point at which the wire is removed when it comes into the carpus. This was a 7-year-old girl, no treatment history so far, type 4 radial club hand. Here again, she was managed by 2-stage approach, showing satisfactory outcome. Again, a 7-year-old boy, bilateral type 3 radial club hand. So here for the right side, these are the images for right side using an eraser or fixator for distraction, and then the centralization was done with an ulnar osteotomy, followed by the correction of left side, and simultaneously the ulnar lengthening was also carried out here with the help of eraser or fixator. So we lengthened around 5 centimeters of the ulna here. And these are the images showing good correction of deformity. Now this was a odd case, a 16-year-old girl with neglected radial club hand and very stiff deformity. So here distraction was done in stage 1 using an articulated gest fixator, and because here the remodeling potential of ulna is not there because she is 16 years old, so centralization is not an option in this child. So we went ahead and did wrist arthrodesis, and we are planning for ulnar lengthening in the next stage. So the take-home message is 2-stage approach for radial club hand obviates the need for aggressive soft tissue surgeries. In younger children, serial casting is sufficient. to distract the soft tissues. But in neglected and more older children, you need JES or Elizarov for distraction. Ulnar osteotomy should be added if ulnar boring is more than 30 degrees, and wire for a longer time provides adequate time for remodeling. Thank you very much.
Thank you, Nitin. Again, forearm, continuous hammering on the same thing. It's difficult to treat radius and ulna with Elizarov frame because of the close proximity of multiple tendons, vital neurovascular structures, and Dr. Srinivas Reddy has elaborated how many tendons, how many muscles, and how many nerves and vessels or something like that. There is need to maintain supination and projection by keeping the superior and inferior radioulnar joints intact, and range of motion of the fingers and wrist and elbow for day-to-day activities, which is most important, which is mostly forgotten. Non-union in the upper limb leads to reduced function due to stiffness of fingers. This is the one which you have to maintain by regular follow-ups and regular physiotherapy, otherwise they will go for stiffness and it is very difficult to bring them back once they are stiff. So functional impairment is frequently exacerbated by restriction of supination and pronation of the forearm caused by angulation of the radius and ulna, and also due to subluxation of dislocation of the distal or proximal radioulnar joints. Deep infections, damages of tissue envelope, and long periods of upper extremity disuse complicate these difficult injuries. Coming to the cases, aseptic non-union ulna, upper third of ulna treated with DCP, ended up with the non-union. Plate has been removed, and tricortical bone grafting from iliac crest has been taken with the same size, and it has been pre-drilled and inserted over a square nail. But I am not happy with the compression there, so I have added 2 rings, one above and one below, and given compression, and you can see good union and also good range of motion of the elbow, wrist, fingers, everything. So it need not be pure Elizarov, you can combine with anything, but you finally at the end of this thing, you have to have a good result and good range of motion. That is more important. Another case of infected non-union ulna, a simple non-union, some small raw area was there, but that has not united on native treatment, and he came with this situation, and Elizarov frame has been applied to ulnar itself, only ulna, and you can see good range of motion even with the frame on. This is the final result, very good unit, but only thing is a small sinus or lytic area remained, but there was no sinus and no active discharge. Compound fracture of the upper third forearm with the vascular injury. Because there was no vascular repair person in my place, he went to a higher center and he came back after 2 days with the VIC. They also have not repaired anything, and I have done open ligation of the radial artery, and Elizarov fixator was applied. That is the marking they have done at the higher center. And I managed compound fracture with the final union, and some VIC has remained. Infected non-union ulna post-plating with the neglected dislocation of the upper end of the radius, like Monteggia fracture dislocation, but the first person they have not taken care of the dislocation, and so he came with the persistent dislocation of the radial head with the non-union at the fracture site. In Monteggia fractures, if you don't take care of the second usually this goes for non-union. So Elizarov fixator application has been done to ulna only, leaving aside the radial head dislocation. You can see the range of movement here at the frame up. This is more important. I want to stress on this point. So good range of movement even with the dislocation of the radial head, and so I have not manipulated it any further. He is happy with the result. In non-union fracture, both bones infected, one bone nailed, because that I felt that is not infected, so one bone has been nailed and the other Elizarov etc. applied. And you can see good range of motion of wrist, hand, fingers, and you can see good union in this case also. Another case of both bones, forearm plated, got infected with loosening. One plate removed initially and the other after some time ended up like this last X-ray with me. Elizarov frame applied. Even with the frame on, and after multiple surgeries, before she could get a good range of motion, and Elizarov frame has been applied for both the bones in this case. With a differential, with the same ring you can go for it, or sometimes you can go for a different ring, half ring on one side and another half ring on the other side also you can try, 5/8 ring on one side and something like that. But each should be able to manage. When you apply for both bones, you should be able to manage both the things separately. That freedom you have to keep it. And this is the final result, and you can see that a good range of movement and good union. Now the post-plating infected non-union with absorption of bone more so in the radius. 2 rings in lower segment and 1 ring in upper segment has been planned for radius. Minimal bone excision of ulna and nailing. Gradual compression of ulna if needed after nailing by including it in the same frame with 2 wires above and below. So I planned like that, and I have excised almost a lot of radius, but only minimal ulna I have excised and nailed that ulna, and catectomy has been done at this level to the radius, and this is the nailing. Then all infected bone has been removed, little of shortening has been carried out, and bone transport has been carried out. But to my this ended up in atrophic type of distraction regenerate, and so bone grafting has been done. You can see the bone grafting has been done, and it was also assimilated almost like good union at this area. And but in the recent past, before removal of the frame, this young lady died of MI, maybe post-COVID. Like the Ritesh has shown type 3 and type 4 cases, but this is maybe type 3 or so, type 2, type 3 I think, type 3. And these are the initial X-rays where there is no subluxation of the radius, but the other thing she has afterwards, after some time, by the time she came to me next, and she became like that, dislocation of the radial head was there. And frame applied to lengthen only ulna initially. After length has been achieved, as the region rate is not improving, bone graft added in this case also, and nailing done to radius to correct its deformity. Even after correction of the radius deformity, ulnar deformity in upper third is seen, and so osteotomy of the ulna done and is also nailed to bring back radial head into reduction. Final result, you can see after removal of implant, good correction and deformity, good supination and pronation, but the radial head prominence was seen at the elbow because it was large. In case of significant soft tissue damage or coexisting infection, the placement of the metal implants and bone graft through extensive incisions may be detrimental. Elizarov methodology provides stable fixation without internal implants while permitting movement of the fingers, wrist and elbow. The Elizarov apparatus allows for immediate physiotherapy of the hand, wrist and elbow, as well as early use of the extremity in the activities of the daily living. The majority of patients were able to resume normal working activity. Elizarov treatment resulted in the ablation of the infection, ultimately healing of non-unions and deformity corrections with minimal complication. Thank you.
Thank you, sir. prefer using a Italian arch and oblique support, that way giving a more contour, better contour to move, abduct the limb, instead of a half ring or a 3/4 ring or a omega ring in the proximal most?
Yes, traditionally, ideally, we should use omega ring to have purchase of thin wire. But if you are intending to use chance pin, you can use Italian arch along with public support.
And second question, sir, while passing the wires, do you use any stimulator, nerve stimulator to know whether you have entrapped a radial or a musculocutaneous nerve in the embedded nerve in the wire trajectory?
No, in last 29 years, this is the 30th year of my Lizaro practice, I have not used a single nerve stimulator.